I feel very honored to be here. Of course, also like from the student perspective, I will present a topic that's like very close to my heart because it accompanied me a lot in my master's. Actually, I was working with adolescents mainly, and I figured out really quickly that eating disorders are extremely common in adolescence. We will talk about why this is the case. And I also want to give you a little take on the role of attachment, but this comes mainly not from the literature, but really from my clinical experience. So first I give you an overview over the eating disorders and why this is important in adolescent mental health, and then talk about the role of attachment, and we can discuss about different topics. Okay, so let's check. This works perfect. So in general, don't worry if I say EDs, okay, from now on it's eating disorders, because in the literature we always shorten it, it's too long of a word for the efficiency of the papers and the articles. So EDs, the EDs I'm talking about today are actually serious psychiatric disorders, so I'm not talking about tendencies or some traits that people can have that are transitory, but I'm really talking about the severe psychiatric disorders where there's abnormal eating behaviors and weight control behaviors. And there are three main types in the literature. The first one is anorexia nervosa. This comes from Latin. Anorexia means you do not eat, you restrict yourself in food intake. And nervosa means that it comes from a psychological point. So this is very important because there is in medicine anorexia that is not related to psychiatry. Anorexia where, for example, a patient who has a cancer treatment doesn't have appetite and doesn't eat. So this is very important. When you see anorexia nervosa, we talk about the anorexia we think about where people restrict themselves in eating. And this is also the type of eating disorder I have the most experience with, and that is the most common in adolescents, at least where I worked in France and in Germany. And the second type that's very common is bulimia. And actually, bulimia nervosa is also on the rise. And it means that there is like an interchange of behavior of restriction, but then the person would struggle with this restriction, and in moments of emotional, can be strong emotions, let's say, they would have these episodes where they would binge eat or eat a lot, or after a meal have the real urge to get rid of what they just ate, and they would have vomiting behavior, purging behavior. This is also something that's very much on the rise. And by the way, there's also a gender thing where we think a lot about girls who have eating disorders, but the boys' eating disorders are really on the rise, especially in France. There's a lot of research about this, and I wrote my master thesis about a case of an anorectic boy who was 18 years old and who nearly died from it, who was in hospital for 9 months. So this is very important also when you work as a counselor or therapist. There is a gender bias. We often think that it's girls who have eating disorders, but there are more and more boys who also have this behavior and who have severe disorders that are not detected by their doctors because they do not know that boys can have these disorders. And the last one is the binge eating disorder, BED. This is one of the more recent classifications of eating disorders. Binge eating is mostly in times of emotional distress. People would go and eat a lot. And then there is a lot of guilt and a lot of shame when they eat a lot of food, but they will not have the purging behavior like in the bulimia. And when you see these three classifications, if you work in a clinic where there's people with eating disorders, often the anorexia nervosa, you see it immediately. It's a very physical illness, and this is what makes it difficult to treat because it's between psychiatric and physical. You have to treat the physical aspect because these people are literally dying from their psychiatric disorder. So this is very difficult and a challenge in hospitals, even specialized hospitals, because you always have to think of the nutrition plan. You have to ask them questions that a doctor would ask who's not a psychiatrist or a psychologist. And so this is a slippery slope because you have to balance between psychotherapy and between the somatic care. And so the anorexia nervosa, you would see it immediately. Like we say in German, we say they're only skin and bones most of the time when they finish up in hospital, and they have a very low heart rate, so they have the risk to die in sleep when the heart rate goes down. So it's a very dangerous disease. In bulimia, sometimes people keep their natural weight. Sometimes you don't even see that they have an eating disorder. Sometimes they gain weight. Sometimes they lose weight, and often there are big fluctuations in weight. And with binge eating disorder, sometimes there's overweight. Sometimes it's the normal weight. Really, you cannot always tell who has an eating disorder just from looking at them. So this is important also in counseling and in psychotherapy. And what is also important is that all these disorders are frequently accompanied by weight fluctuations, but also by impaired social functioning. So this is an indicator and also an early indicator in diagnosis. It can have really a profound impact on the quality of life and social adaptation. So sometimes you can see an adolescent who is isolating themselves, doing a lot of sports, all alone, not in a team, maybe having picky is a picky eater, only eats certain legumes or only certain things, and this can be a sign that they're entering in an eating disorder. So it's also very important to listen to these things. And why are we talking about eating disorders in terms of an adolescent mental health problem? It is predominantly emerging during adolescence between 10 and 19. Really the age that I saw most in clinics is 12 to 14, but there are also older ones, often the boys who are diagnosed later when the eating disorder is already more severe, between 16 and 19. So, and by the way, this is also maybe interesting for you. If you work with adolescents, there's always this critical point, especially in Europe, where they are 18 and then they switch from the psychiatric child care to the adult care. And this is very difficult for them because in the child psychiatry, we really try to envelop them, give them a lot of affection, give them a lot of arts therapy, music therapy, and then they continue to being with people who are 50 or 60 and they're in the same eating disorder realms with these adults, and this can be very, very harsh for them. So yeah, this is some insight from what I know and from the literature. Next slide. So is this actually a Western or a global problem? I think this might interest you also. I found one very recent study that was published this year where they did, I really have to send you this paper, it's very interesting. You can find all the non-Western regions, actually also Middle East and Egypt, and you have charts and scales. I don't want to go too much into it because we want to talk about attachment, but you can see that actually I think they did a study from 1990 until 2020, and they compared all the numbers in all the regions, and you can see that everywhere in the world there's more and more report of eating disorders, and in the Western countries especially, because in the Western countries we have specialized centers. So this is also a bias actually, because we do research on these people, we recruit these people for research, so we also pay attention, is there an eating disorder, could we, sometimes there's ethical things going on also, okay, someone has a disorder, we recruit them for research, so this is also a bias that you have to be aware of. So eating disorders are actually not at all a Western disease that only concern girls from wealthy families, what we always thought to be the case. But you see many different social classes, the services that are specialized where I work, and they really paid attention to not only have this kind of wealthy families who have access to, who have money, who have access to good health care, but also people from lower classes and this is an important thing that's going on right now in the West, because we feel that actually this bias is created by who has access to care and not by who is anorectic or who has an eating disorder. So it's actually a global burden, and among adolescents and young adults it is increasing. This is a very recent study that shows this worldwide map that I can send you after the talk, and there's really an urgent targeted intervention needed to address the growing public health issue that's going on. And the prevalence of EDs in non-Western countries is lower, it is still lower, but let's say abnormal eating attitudes in non-Western countries have been gradually increasing, and if you see what is going on in the future and you see all the papers on it, you can only imagine that it will be rising more and more. Exactly like addiction, by the way. Addiction is also a psychiatric disorder that's on the rise. And never forget this limitation that I already touched on. There is an underreporting in underdeveloped areas that do not have specific care, so this is also reflected in everything I'm presenting to you and all the numbers. We can imagine that there's a huge number of people who are never diagnosed with an eating disorder, who have a severe eating disorder, because they do not have access, because they come from a region where this is not a thing. This always keep this in mind, and also keep in mind the gender bias, that there is a lot of boys who have eating disorders, and this is increasing very fast. There's also commonly associated disorders, because we always say in the clinics where I work, we always say an eating disorder is not a disorder. There's always an underlying disorder, for example, severe depression, severe anxiety. And sometimes there is severe anxiety, but the patient will not at all have anxiety in what they say. And this is very interesting because in psychiatry you often face situations where you're with people who are extremely depressed but don't tell you they're depressed, who are extremely anxious who don't tell you they're anxious. And it's so individual and personal, and you always have to go case by case and really listen to them and take time to understand where they come from, what is the motivation for them to restrict themselves, where do they come from emotionally, on a relationship level. And so depression and anxiety are very common in eating disorders, but also substance use disorders, and actually eating disorders are often associated to addiction. I really did a lot of research about this for my master thesis, and I think it is an addictive behavior, of course, that often is also associated to excessive sport, excessive performance in school, etc. But there's also a very big difference between substance use disorders and eating disorders. So I will not go into detail, but you should not only think of eating disorders like substance use abuse. This would be too easy, and it can also be intricated with personality disorders. We very often have links made between borderline personality, for example, and binge eating disorders, or bulimia or anorexia nervosa. I will talk about this later in the clinical part. And in very severe cases, this is what I saw a lot, in very severe cases where really the adolescents were about to die from anorexia, this is psychotic disorders. And there's a very interesting thing that I never read about in the literature, but that I saw a lot, that actually the eating disorder is keeping the personality together, and they feel better on the psychotic level when they don't eat. And the moment they eat again and they gain weight, hallucinations come up, they have paranoia. This is something I saw very often. So here the eating disorder is functioning like something that balances out some psychotic traits, actually. And there's a very good website that I can also send you afterwards, where you have all these informations in a short list. So what are the projections? About 86% of women have eating disorders, so there's still much more women than men. But also because they're underdiagnosed, the men are underdiagnosed, and the men showed a very much faster increase than the women, because we already know about the women's also the diagnosis bias. Persons aged 20 to 24, this for me was very surprising, had the highest burden and fastest growth, because normally we would think it would only touch adolescents, but actually older adolescents, young adults between 20 and 24 have the highest burden, and the numbers are on the rise. And the projections suggest that it will be rising continuously through 2035. And we also have more and more literature on parallels between personality disorders and eating disorders. For example, binge eating and borderline personality, as I mentioned before. And there's also new categories. Every year you find a new eating disorder category. It's a bit like the DSM style, that you invent a new name for something that already existed, but you didn't name it. And this is actually... I come from a university where I learned that DSM is the devil. But this is actually not something I want to support, because I find it important that you classify sicknesses in order for people to diagnose, in order for people to get help. But with eating disorders, as it's very recent and there's trends that also go over social media, there's always new names for things that already existed, and sometimes we wonder, do we need, for example, to call this an avoidant restrictive food intake disorder, or is it just something else or linked to another disease that we already know? Yeah, it's a personal opinion on this, but it's a big discussion in these clinics. So let's talk about eating disorders and attachment styles. As I told you, I will just give you some hypotheses that can make us associate and make us discuss. I give you a clinical perspective from my work of 2 years in specialized institutions for eating disorders with adolescents. And I choose to to take an angle where I would come from the clinical experience, and then we can make links, and I will focus here on the anorexia nervosa, so the restrictive type, because this is the type that I know the best. The most patients I saw had anorexia nervosa. And one trait that they really all have in common, I think I never met a patient who didn't have this trait, it's an extreme perfectionism. There is really high expectations on themselves, but also for other people, for their parents, for the other adolescents. There's a climate of performance and of excessiveness, and they also overperform often in school, in sports. They do a lot of things at the same time, and sometimes you can feel this climate, this perfectionist climate that also comes from home. I have to say that because we talk about attachment, but at the same time I want to tell you that it is never ever helpful, no matter where you work in psychiatry and clinical psychology. It is never helpful when you work with adolescents or children to blame the parents. This is something that we really should not do because they are your partners. If you want to help the child, you have to cooperate and work with the parents. And this is something that's very difficult because in psychiatry, most of the time we spend the time talking to worried parents who don't want their kids to take medicine, who don't want their kids to go to art therapy, who don't want their kids to do who are afraid because it's out of their control, and this is also normal. Yeah? We have to try to take their perspective and think, okay, we take the child out of the family, and the child is somewhere with other children. They don't know what's going on, and they're afraid. They have anxious feelings about this, and so we can say that often we see this perfectionist climate at home, but we do not want to blame the caregivers for what is happening to their child, because let me tell you, there's many perfectionist climates at home, and not every child has anorexia, not every child has a problem. Some children get out of it well and feel good about this, or even have a healthy perfectionism or high expectations, but not too extreme. So yeah, this is there's emphasis on performance with these patients, but we do not want to say that everything comes from attachment and how they grew up. So let's do a link to attachment. I think this perfectionism really much comes in a psychodynamic perspective from a disturbed self-worth and self-image. And this is often reflected in the symptom of body dysmorphia. So body dysmorphia is this phenomena where they would be extremely thin. They would weigh under 40 kilos or maybe under 30 kilos sometimes when it's very extreme. And they would see themselves in the mirror, only skin and bones, and they would say, I'm still overweight, I cannot lose this weight. So they have a totally disturbed body image. And very often this comes from an unconscious, mostly unconscious feeling of being unworthy of love and affection, of being in a relationship, of talking about it also. It's very difficult for these patients, for every patient who has an eating disorder, no matter what eating disorder, to talk about it, because it's extremely intimate, it's extremely vulnerable, and sometimes in adolescence they're also flooded by hormones, and they do not have a reflection on what they do. They just spiraled into excessive performance, and they do not really know what happens to them. So this is something that you see a lot. And then all this performance can act as a currency, doing excessive sport, having the best grades all the time, as a currency of love and attention, where they get positive feedback not only from their parents, but also from teachers, from other adolescents. And I think this is something where we can, of course, talk about the feeling, maybe it's not in the reality, but the feeling that they integrated of, I have to do so much to get love and affection. I have to do so much, I have to give all this effort in order to get attention and to feel worthy of being seen or being listened to. This is one link that I find very commonly in this clinic. There's another trait that is the fear of intrusion. So this is a bit more abstract, let me explain it. Very often these patients have a fantasy, this is a psychoanalytical concept of it, so this is a fantasy of autosufficiency. There would be an adolescent in front of me who's 12 years old and who would tell me, I don't need my parents, I don't need my school, I don't need anybody. I have my schedule, I eat what I want, I prepare my own food. They seem totally autosufficient, which is of course not good for a child, an adolescent, who should have the feeling of, oh, I need my parents, we are a group, we eat together. They really try to have this it's a very narcissistic defense mechanism where they would this linked to this fear of intrusion, and then they also have these difficulties to communicate feelings and intentionally blame their suffering. So sometimes you talk to them, they're 12 years old, and they sit there and they tell you, listen, psychologist, I'm here, I don't want to be here, I have no problem, I'm eating. And this is very difficult for a therapist, of course, because you're there's a child who needs help, but they do not want it. It's their parents who bring them to hospital, and you're there, and you have to try to connect with them and have a relationship with them. So let's draw some obvious links to attachment here. These patients very often have extreme tendencies in relationships. So when you see the relationship with their parents, in the moment where I see them in hospital, of course, there can be a lot of anger, hate, and total rejection, where they say, I do not want to see my parents. And I'm thinking right now of a girl patient who was 13 years old, who did not speak to her parents for 5 weeks where she was in hospital. She was like, I'm not going to talk to them. They got me here. I don't need them. I don't want to be here. And she was so angry on them that she totally rejected them. And then when she reconnected with her mother, we actually saw that she came from a very symbiotic relationship with her, that it was actually the opposite. She was so close to her and they were nearly like one. They even confused on a language level, they confused each other. They said, I'm doing this, I meant my mother is doing this. It was very obvious that there was a very symbiotic relationship going on that switched to the other extreme. And this is what we call sometimes this push-pull dynamic that we can see in borderline personalities, in people who also less extreme. There doesn't have to be a personality disorder in order to do the push and pull dynamic in relationships, but we see this also when they interact with other adolescents. They say, oh, I need your love, be my best friend, and then later they have a fight. They say, oh, please, this is intrusion, this is too much, this is too far, you're touching on my intimate space. And there's this dynamic that you find very often in eating disorders, that they feel either intruded by someone or they feel abandoned. And this is a huge conflict that you have to work on. And considering that you're the therapist who will meet them, maybe, or the counselor, you will see that it's very difficult to establish a trust relationship with them, and you will always have the feeling, or very often have the feeling, that there's a huge distrust. They will not tell you things. They will lie to you, of course, about their addiction, about their eating behavior. They will try to tell you that it's like this and make up it a bit, camouflage some things. And this is actually why, in my conclusion, I will talk about also about therapists. Is this? Perfect, thank you. I forgot the last 5 slides, thank you very much. Just too much multitasking. So for my conclusion, I will get back to the therapist after this little question, because of course you're wondering, we're talking about attachment. Is there one attachment type that is really commonly associated to eating disorders? And my response would be yes and no. Because I was talking a lot about attachment that is insecure, that can be sometimes disorganized, for me very linked to psychotic disease. But most of the time you see people, especially in anorexia nervosa, that are totally avoidant. They really don't want you to intrude them, don't want the parents to intrude them, and they think they're autosufficient. And we can imagine that this is something they integrated very early on in their life. But then at the same time, when you meet these patients, they have the same symptoms physically visible, but they're such different personalities. And this is actually a real learning for me when I studied clinical psychology. In every clinical disease, not only eating disorders, the symptoms are always intricated with the unique personality of the individual, and you always have to go case by case. You can never say, okay, this patient is in this class. Sometimes they switch. Sometimes they have months where they restrict themselves, and then they would go to bulimic symptoms, and then they would not have symptoms at all and gain weight and be healthy again. It's really, it is really so individual, and especially eating disorders, because it's not only the personality traits, the attachment tendencies, and the behavior that varies from patient to patient, but also, and this is something very important I find, it's so cultural. Food, eating, nourishing role of the mother, of the father, this is maybe the most cultural thing that exists. I always find that food is such a reflection of a culture, of a society. I can give you an example. I'm German originally, and I worked a lot in France. And French people put a lot of emphasis on eating together on a table, taking their time, breathing. Okay, we have our food slowly, and we talk to each other, and we enjoy it. German people, they take their banana between 2 appointments, and they run from one appointment to, and they eat the banana, and the French people would think they're totally crazy. This is such a simple example, but this is really how. And also when I worked with mothers, migrant mothers in Paris, you would see how the mothers from the African continent, no matter where, would feed their babies, and the French caregivers would say, "Oh, what are they doing? This is so strange. I don't understand how they're feeding their child." You see, this is really how unique it is, and how much you have to also see the prism of culture in every eating disorder, in every psychiatric disease, actually. So a little conclusion from the therapist's perspective, thank you so much. First of all, be prepared if you work with an adolescent population in general, you will get probably rejected and feel a lot of ambivalence, because adolescence is one of the most turbulent phases on a developmental, from a developmental standpoint, a lot of hormones. We even say in psychiatry that until 25, people are flooded with adolescent hormones that can make the psychiatric disease worse. You often see this with schizophrenic patients, psychotic patients, who would feel much better when they're in the end of their 20s compared to the beginning of their 20s. So this is something you have to keep in mind, but also realize that the rejection and ambivalence is a symptom. It's a reflection of how the patient, the client, felt treated themselves, and they are projecting this on the figure of the therapist. So this is something they know, and so your job is actually not to align with this, but your job is to oppose something to this and to say, okay, you learned this, but I can propose you this, and this is how you can make them shift on an attachment level. You can show them this can be a relationship, this is not in the same realm, this is not what you know, we will not repeat what you know, we will find something else. But for this, of course, you need a lot of patience, and always remember that a strong therapeutic bond can be difficult to achieve, but it's worth the waiting. And especially with this presentation, for me, it's very important, because maybe you don't want to be counselors and therapists, and maybe this is just maybe you will just stumble upon people that maybe have an eating disorder or these tendencies. The awareness is really key. So the awareness of the risk at adolescence, of the entrance in eating disorders from 10 years on up until 19, 21. It's so important to be aware of how an eating disorder looks like, what types of eating disorders there are, to have the ability to detect lingering eating disorder behaviors and tendencies. So thank you so much for your attention. I have a little text for you also. The last one is just some references. Thank you so much.
Thank you, Laura. That was very interesting. I know there's a lot to say about this, so you're able to wrap it up in a very short period of time, very comprehensively. So that was amazing. Thank you. Any questions before we get to
I do have one.
Yeah.
So you've talked about the attachment. It seemed like most of it was exploring the attachment of the client with their parents. I'm curious what's common in how the parent treats the child in these situations.
You mean in situations of total rejection?
With I know that there isn't one specific thing that changes from one client to another, but is there anything, a common theme in how parents treat children who then end up developing eating disorders?
Okay.
Or how their relationship is like, but from the parents.
Yeah, I can give you insight into this, but don't quote me on this, because of course personal bias, what I saw. I often saw parents one parent would have a very, very close relationship to the child, where there was confusion between the two. So an attachment that was very symbiotic, a relationship that was very intense like this, and that created a dynamic where the child got sick and often verbalized also that there is too much pressure on them because of this confusion. And then they would, this is my understanding of it, try to extract themselves from this pressure, because what is the worst thing as a child you can say to your parent? I'm not going to eat your food. This is the worst insult, even a baby that's nourished by the mother, this is the worst thing for the parent, and this really shakes them. And you see this in the parents. The parents who have kids with eating disorders are extremely worried. They're so anxious that their child is going to die, because this is really the fortune if they don't stop, especially with anorexia nervosa. So you can see their difficulties, and also a symbiotic thing there, that they think they are going to die if their child is dying. But of course, this is a very tough topic to talk about, because seeing a child not eating is really the worst opposition and rejection they can also give to parents. So you see very anxious parents, and by the way, we have a lot of group therapy for parents who have kids with eating disorders, because they need this identification, because they feel like the worst parents in the world. And this is also why we do not want to give them more guilt than they already have. And also for the siblings, by the way, this is very difficult. We have also therapy groups for siblings, because many siblings who have a sibling with an eating disorder, they become so depressed because all the attention is on the child with eating disorder, and the other child feels unseen and can really spiral into depressive thoughts. Yeah.
If I can also add to this, and I think it's already in between the lines of what you're saying, I see it very commonly as in a dynamic of control, trying to regain control when parents are putting a lot of pressure in terms of controlling the child's behavior or the adolescent's behavior. In many cases, it can be their only outlet to try and regain control through, at least I'm controlling what I'm eating, and at least I have that aspect of control over my life.
Exactly. Yeah.
Thank you so much.
Thank you for the question.